Good morning. We will get started in just a couple of minutes. Please get some coffee, find a seat. I know it's spring break, so some people are out of town, and we have some people watching online. I think we are about ready to get started. I have been so excited about this speaker for more than a year. Some of you may not know Daniel Markwalter because he's usually in children's chapel with his kids and wife, but he's on faculty at the UNC School of Medicine. He just admitted he wears a lot of hats, and he will describe which hat he's wearing today. But thank you for being here. This is the end of our Leaving Legacies series, but we can keep this conversation going for a long time. I feel like it's so important and actually, in a weird way, so fun to talk about. So I'm going to hand this over to Daniel.
All right, thanks. Hey, everybody. My wife is waving in the back. So you probably, because we're mostly in Children's Chapel, probably the most of the time you see us is when we're coming up for communion and our daughter Ellis is charging up there in some outfit that she's chosen for the day. So that's us. And we've been here for a couple years now, and Boyk and I had talked about doing a session on some of the work that I do and how it applies to the lives of those in the church, and I'm excited to be a part of this series. I will say, as Boykin said, I'm in the School of Medicine. I don't know if they would require me to say this, but everything I'm saying today is my own personal views and opinions about things. It has nothing to do with how UNC views things or my department. I have a split role there. I work 50% of the time in the emergency department and 50% of the time in the hospice and palliative medicine group. And so today I am mostly here as a hospice and palliative medicine doctor, but I'm also happy to take questions about how that intersects with emergency care, because that's really where my niche is. And I initially kind of framed this talk around palliative medicine, hospice, and end-of-life planning, but I want to acknowledge that a lot of what we're going to talk about is not just end-of-life care planning, but just planning for life's phases, and these things apply at all ages, from childhood on up. And when we talk about some of the resources I have, I even have some resources for kind of young adults and adolescents as well. And I got the sense over the last few weeks, because we've been in different classes, that y'all have done some work on end-of-life care planning and advanced care planning. And so my hope today is to plug plug what you've heard into some of the medical perspective on that, and how maybe physicians think about some of the planning for life stages. I will also say that I'm not much of one for just standing up and talking at people. My work is very conversational in what I do, and so I'm used to just sitting down and having conversations with folks. So I have some slides that I'm going to share just to kind of get a conversation started and share my perspectives, but my hope is that this will be actually more of a conversation, some time for discussion about your experiences of family members, and kind of questions and answers as well. Thanks, Morgan. Yeah.
Unfortunately, our clicker is out of battery, so I am the human clicker, and will also run the mic.
All right, the first two slides I have are just about what is palliative care and what is hospice, because those are the two parts of my title. But they're often confused and have a lot of misconceptions about what they actually are. And so just to clear those things up before we get in, so my work is predominantly as a palliative care doctor. And so what that is I tell people we are a serious illness support team. So we're involved in the holistic care of individuals who are seriously ill. Common examples are cancer, malignancy, but really any serious illness care. It could be dementia, it could be traumatic injuries, whatever it might be. And I tell people that we're sort of the quality of life team. So we sit down with patients and families, and we think about and we talk about how to improve their quality of life as they're going through a serious illness. And so that falls into three main categories. One is supporting medical decision making. So thinking through what's going on medically and how we can make decisions that align with who somebody is as a person. Lots of people have opinions about their medical care, and so we're looking to understand who that person is, and when they're faced with medical decisions, help them make decisions that seem to align with their preferences and values. The other thing we do is a lot of symptom management. So as people are going through serious illness, I'll use cancer as a common example because that's just where we kind of have a really high symptom burden, nausea and vomiting from chemotherapy, pain, whatever it might be. We're there to kind of help support their symptom management. And then finally, we do a lot of psychosocial support, emotional and spiritual support. And so we really view ourselves as kind of the kind of holistic side of serious illness care. I joke with people that palliative care probably should not be a specialty. It should be something that everybody does, and everyone should get all of these things in their usual medical care. But by nature of modern medicine, sometimes folks are too busy or caught up in other things, and so we've kind of had this little subspecialty created of palliative care that helps support kind of these more holistic needs. And then I should say, palliative care is frequently confused with end-of-life care. Palliative care can be provided at any point in someone's illness. We're seeing patients who are also working their way toward cure as well. So it's not just folks who are progressing to end-of-life care. Sometimes people are hesitant to go visit a palliative care doctor if somebody recommends that they do. And I want people to know, if someone says you should talk to a palliative care doctor, say yes, see if it's for you, because I think we do a good job of helping support people's quality of life. Sorry.
These are
all good.
there. I did not make those move.
That's okay.
Is this where you want to be?
I think I just said that because I knew it was on the slide, so we got through that. And then hospice. I've got this little diagram here. So hospice care is a tiny little portion of what we do. So within palliative care is end-of-life care, and then hospice care is just a specific way to provide end-of-life care. In the U.S., I know it's on the slide, so I'm okay. But is it on a timer or something? It must be. Okay, no worries. So hospice care in the United States it's centered around an insurance benefit. So there are some technical definitions of what hospice is. So in general, it's provided to people who have a 6-month prognosis or less. So their life expectancy is 6 months or less. But really what it is about a philosophy of care. And the philosophy of hospice care is to provide comfort and quality of life at the end of life for people. Especially folks who either no longer have treatment options available or who have decided to forgo further treatment of whatever their disease process is. So folks who have decided not to do any more surgery or chemotherapy or radiation for their cancer, for instance. perhaps because, again, there aren't treatment options available, or because maybe the side effects and the burdens of that treatment are just too great, and they're really reducing somebody's quality of life, and so switching to a more kind of comfort-based kind of care. And hospice care is predominantly provided in a home setting, which is a common misconception. A lot of people think about hospice homes, like hospice units where somebody goes to receive their care. But the vast majority of people in the United States are receiving hospice care in a home setting. So that could be their house, apartment, assisted living, independent living, whatever it might be. That's the most common way to receive it. And in general, it's a team. There's physicians, nurses, aides, social workers, chaplains, who come to the home setting and provide that care there. And the most common one who's in the home is going to be a nurse, but they also provide all the medicines, any medical equipment, oxygen, hospital beds, whatever it might be. And the thing I tell people about home hospice is it's not 24/7 care. It's not the same thing as round-the-clock care, but touching in maybe anywhere from once to several times a week to provide care in the home. And then there are hospice homes available for folks who need kind of more intensive nursing care, kind of round-the-clock nursing care, and that's really what the hospice homes are set up for. We can go to the next slide, Boykin. Thank you. All right, so that's just a little bit about understanding kind of the palliative care and hospice side of things, which I get asked about a lot, and some of the misconceptions. But what I really want to focus on today is how we think about planning for our healthcare progression throughout life. And I just want to put up one example. There's been lots written in the medical literature about how religion and spirituality affects people's healthcare preferences. And you don't have to read the details. The point here is this was like a big review of the literature of everything that's been written about spirituality and end-of-life care, looking at the cancer population. And the bottom line here is that people who are religious or spiritual in some way tend to get or desire more aggressive end-of-life medical care. And this is not just Christianity. Lots of faiths were included in this review. And so basically this is saying that people with religion or spirituality tend to get more aggressive end-of-life treatment. So that would be things like maybe spending time in the ICU at the end of life, getting really intensive care, maybe being on a ventilator, the kind of the most aggressive forms of treatment. And also lower rates of advanced care planning. So they did less planning for end of life if they were more religious or spiritual. And I think that's important for us to keep in mind. I have no agenda in talking to patients about what they want their care to be like. And some people, it's really important to receive the most aggressive end of life care possible. But we want that to be an informed decision that's actually in line with what people want, instead of something that happens by default, which is sometimes what happens to be the case. And so on the flip side, if you have spiritual care provided by a medical team, people tend to then request less aggressive medical care. And so I just want us to keep that in mind as we're thinking about, as a spiritual community, how we're planning for our own life transitions. Perfect. And then I'm going to end with just a few kind of statistics about the state of end-of-life care planning in the United States that was done by the Kaiser Family Foundation, just so we can kind of think about where we're at as a community on these things, and then we'll just kind of go into an open discussion. Next slide there, Boykin. Thank you. So just in terms of preferences, so it probably comes as no surprise that most people want to die at home. When they're thinking about their death, they have this vision of dying peacefully at home. And that's 7 in 10 Americans. But if you ask people, where do you think you'll die? It's not 7 in 10. Most people think they're going to die somewhere else. So 4 in 10 actually think they're going to manage to die at home. And then looking at where people actually die. So on the right, 2 in 3 Americans have had a death of a loved one in the last 5 years. And when you ask them where did that loved one die, only about 34% died at home. Now again, that's not to say that everyone should die at home, or that we want everyone to die at home. It's about aligning preferences with where this care actually happens. Next slide, Boykin. And just think about who is doing advanced care planning or end-of-life care planning. it makes sense as people age, they do more of this planning, and that's true. So you can see those 65 and older, about 73% have done some amount of end-of-life medical planning. Much lower in kind of the young adult adolescent category, which 18 to 29-year-olds, it's 28%. But again, if we look at the overall like adult population, just over 50% have done some planning. So there's a huge amount of the population that hasn't really done any conversations or planning around these things. And I think over the last few weeks, you'll have talked some about the importance of that and why that's helpful. And we'll get into that at the end about why it's important to have these conversations. So who's actually written down their medical wishes? So it turns out only about a quarter of the population have actually written down their medical wishes. It does increase with age. For those 65 and older, it's about 50%. So as a palliative care doctor, as a hospice physician, I'm very big about people at least having the conversation and certainly writing down their medical wishes if we think that would be helpful. And we'll talk some more about that momentarily. And most of the time it's because people just haven't, like life is busy, people haven't gotten around to it. And I totally get that. Next slide. All right, so this is the open discussion part, and I hope people will participate with this. So I've got 2 slides on just things that come up in my work all the time that influence medical decision making at life transitions or at the end of life. And so I want to go through some of those, but then open up to the floor to talk about how this impacts maybe the way you're thinking about life transitions, how family members have gone through life transitions. So the first point is to say, I view the most basic form of medical planning is who's going to help make decisions for you if you can't make decisions. And that could be because you're sedated in an ICU. It could be because you're undergoing surgery. Who's going to help make decisions for you? And the bottom line is if you've not designated somebody, there's actually a statute in North Carolina that designates who we should go to for those decisions. It starts with spouse. And then the next kind of category is the majority of adult children and parents. And then there's sort of this hierarchy that goes down to siblings. There's this hierarchy. The reason I bring it up is I've had encounters with folks where they didn't realize that there was this hierarchy that sort of we were legally bound to if they don't designate anybody. And it turns out they really don't want their parents making their decisions for them or their children. They really want somebody else to. And so I say this jokingly, if you're not thrilled about the idea of like your parents or your children making medical decisions for you, it's important to designate somebody because we will go to whoever's in that hierarchy. And they're welcome to decline it. The other piece I'll say is there are many people who are separated but not divorced, and legally speaking, we still have to go to that separated but still legally married person. And if that doesn't sound appealing, then it's important to designate somebody. Again, they can decline to act in that role, but we at least have to go through the hierarchy. And then the conversation about life stages, about healthcare planning is way more important than the actual document. I believe in documents and I think they're helpful and I fill them out with people, but in large part because they're a vehicle for having a conversation. Many of the documents that we'll talk about, especially kind of like the more legalese advanced care planning documents, like the North Carolina has released their own advanced care planning form. It's full of language that's really hard to kind of understand. It's a little bit vague about what it's talking about. It doesn't talk about medical specifics very much. The document itself is not that helpful. What's helpful is the conversation. And so as you're doing healthcare planning, advanced care planning, filling out documents, I highly encourage whoever you want to help make your decisions if you're not available, or even if you are conscious and can make decisions, if you're going to make that decision with somebody like a spouse, involve them in whatever that advanced care planning is, because ultimately they're going to need to know what you're interested in and help support that. And so the conversation is way more important than the document itself. And what's that conversation like? So when I'm talking to people about transitions through life, it really comes down to what are someone's goals, and I'll give you some examples of that in a second. What are their values? What do they hold dear? And then what does quality of life look like to them? because ultimately any medical decision is about understanding what is that medical thing going to help me achieve. Maybe it's in terms of longevity, maybe it's in terms of curing or not curing a disease. So what is that thing actually going to help me achieve? And then what do I believe is important in my life, my values, that would influence that decision? And then ultimately, when I say quality of life, it's really about balancing the risks and burdens of something. Obvious examples are when people undergo surgery, people understand that there's some risks associated with surgery and some potential benefits from surgery. But understanding whether the impacts of that intervention, surgery or not, is going to help somebody's quality of life or not is really, really important. Because I hate to be cynical about it. Unfortunately, medicine's really good at putting people on kind of the default pathway. These are the things that we do. Without asking whether these are the things that people want and whether they're going to help them achieve some specific goal or quality of life. And so goals. So for instance, I talk with some patients who perhaps have been given, maybe they know that their prognosis is 6 months or so, and that 6-month window includes a really important life event, like the graduation of a child or a grandchild. And so I have some patients who might, in other circumstances, choose not to pursue some life-prolonging measures, who will for a period of time so that they can make it to some life event. And they're willing to accept some of the medical burdens that come along with that. So for instance, knowing that it might mean a little more time in the hospital or more visits to the clinic for chemotherapy and the side effects that come with chemotherapy in order to try and prolong life to reach some specific life event. So that's like just a very common goal that I hear. And then values. So some folks that I talk with value life prolongation above all else. I'm using kind of some very black and white examples, but above all else. And they will take any amount of medical risk and medical burden, whether it's pain, time in the ICU, time on ventilators, whatever it might be, they will take that at the chance of life prolongation above all else. And so thinking about where your values are is important in thinking through medical decisions. And then quality of life, I kind of spoke to. So that's the balance of risk and burdens here for whatever the intervention is. And so I think the value in conversations around advanced care planning, again, are not in the document. It's really about understanding what a good day looks like for somebody. Because I end up in a lot of situations where people are approaching really important medical decisions, and perhaps the patient is no longer able to tell us what they would like. And so we're talking to the family, and the family says, well, we did not talk about this specific scenario. And that is totally reasonable. It is impossible to talk with your family about every single possible medical scenario that is out there. I'm still fairly young in my career, but been doing this for several years now. I still encounter scenarios I've never encountered before. And so there's no way patients and families can think through every scenario and what they might do in that scenario. And that's not really what it's about. So when I talk to people about advanced care planning, I talk to them less about thinking through specific medical scenarios. Even some of the big stuff like being on a ventilator, attempts at resuscitation, the big things that come up, and they're often on forms, so we're kind of forced to talk about them, things like feeding tubes, things like IV fluids or IV antibiotics. To me, those specifics are way less important than understanding the big picture for somebody. So these conversations with patients and family members and loved ones that you're caring for are really about understanding what does a good day look like, what does a bad day look like, and what situations might you consider an unacceptable quality of life. And I think once we're able to kind of understand those parameters for somebody, what they're willing to accept, what they're not willing to accept, and if we're talking about end-of-life care, like what does a good death look like? Once we understand that 30,000-foot view, then we can help people make specific medical decisions about, again, whether it's a ventilator or resuscitation or feeding tubes. Once we understand the big picture, we can help guide decisions around that. But if we start by thinking about all the little individual decisions that could happen, there's just too many of them to kind of go through one by one. And we're trying to align the values and preferences to whatever medical decision is happening. And finally, to say that that conversation that I just described happens over time. So like my values and preferences, you know, as someone in his mid-30s, I know are going to be very different than my preferences in 20 years and in 40 years. And so reevaluating your directives, having that conversation again as time goes along with your family, to reiterate kind of where we're at with, here's how I'm thinking about these things. All right, last slide. And so the final thing I'll mention is seeking medical input is just as important as having the conversation with whoever your like surrogate decision makers are going to be. We want your surrogate decision makers to know what's important to you, but we also want someone in the medical community to know that too, for a lot of reasons. One, so it can be hopefully documented in the medical record, and that helps guide maybe when someone comes in and the family's not available, we have some documentation. But also because, as I said before, it's impossible for patients and families, especially without any medical background, to know how to think about these things sometimes. And so talking with a trusted medical professional about values and preferences and how those things inform medical decision making is important. And so I say that because I already put out some statistics about how often people are talking to loved ones about these things. You know, greater than 50% of the time. But who's actually discussing this with a healthcare provider is pretty abysmal. It's one in 10, which seems pretty crazy to me, because these are also medical decisions. But that's the state of things. And then the last 2 points are about how to be a surrogate and how to be a caregiver. Because wherever we are in life's journeys, those are, you know, just as important as the patient role for a lot of reasons. So one, being a surrogate is about knowing the values, like I talked about. So whoever you might end up being a surrogate for, just I encourage those conversations. And finally, I just want to acknowledge, you know, life's journeys, especially medical journeys, are really hard. And being a caregiver is exceptionally difficult for a lot of reasons. Physically, whether it's nights, it's time up at night, whether it's helping with transportation to and from doctor's appointments, it's hard. And not to be afraid to ask for help and support. Caregiver burnout is a real thing, and people neglect their health to help other people with their health, which is so admirable, but also so difficult. The last 2 points, I see these come up. I see these in my practice, and I don't think we talk about them a lot as a non-medical community. One is, as people are going through serious illness, perhaps if things are getting worse, there's this entity called anticipatory grief, where we know perhaps something bad is coming in the future, whether that's a death or maybe we have an upcoming appointment where we're anticipating getting some bad news. And people start grieving that event or that information before it even happens. And this looks exactly the same as grief perhaps after somebody's death. But people are often able to name it a lot better after the event or after somebody dies, but we're bad at identifying it before it happens, where maybe people are acting in ways that are a little more cold or distant or sad for reasons they can't really explain. And when we kind of sit down and boil it down, we realize it's anticipatory grief. They know something bad is going to happen, and they're already grieving that loss. And so I think naming it and helping people think about it as like this is grief is important, because once we've named it as grief, there are lots of good resources and ways to talk about grief and help people cope and understand what that is. I'll talk about the resources I brought in a little bit. One of the resources I brought is a little pamphlet on anticipatory grief. And then kind of adjacent to that is naming and validating emotions. Whenever someone's going through a medical journey, I mean, it's hard, it's emotional, there are highs, there are lows, and it's okay, and I think it's important to help people process and cope with those emotions. But first we need to name them, because if we're not naming the emotions that we're feeling and talking about the emotions we're feeling, they stay inside of us. And it's just important to talk to whoever our support group is about that, whether it's spiritual support, whether it's the family support, close friend groups, whatever it might be. All right, Boykin, I think I have two more at the end just to acknowledge a few of the medical forms. So there are advanced directives out there that help guide people through naming a surrogate decision maker, that help people think about do they want to focus on life prolonging care, or maybe more focused on their comfort, that are very legal. I know you can't read this. There's no point, don't need to read this. I'm just pulling it up as an example. There are two forms that I consider more medical forms. And so if you're interested in filling out forms with like a physician about some of your preferences for care, one of those forms is called a MOST form. Has anyone seen this before? See a few hands, yeah. A MOST form is a way to kind of fill out orders from a physician. It stands for medical orders for scope of treatment. Every state has some form of this document, but it's a way to solidify some of the big questions that sometimes come up, especially near the end of life, around like, am I interested in the full scope of treatment? Meaning like, put me in the ICU, do all things possible for me. Do I want something kind of in between? Like, I'm okay coming to the hospital, but I'd really like to avoid really intensive care if possible. Or am I more focused on comfort? And if I get sick, please try and care for me at home or wherever I'm located. That's kind of like the first question, along with code status about, being on a ventilator or being resuscitated. So those are the big questions, but it includes some questions to fill out with a doctor around things like feeding tubes, antibiotics, IV fluids. And so that's just a way to kind of codify things a little bit from I think a medical standpoint. And so this form and the next form, which is kind of like a do not resuscitate order, which is signed by a physician. Those are more medical forms that I get asked about sometimes, and happy to talk about code status and some of these other things a little bit more. But I bring these up because I see them in my work a lot, and I tell people, if you're interested in some of these forms, or if you filled one out, this is the intersection with my work as an emergency doctor, which is, if you have these forms, put them on your refrigerator or somewhere where they can be seen, because when I work with ambulance crews, if they can't find these forms, they will default to the highest level of aggressive care. So if people want to set some limitations, make sure this form is visible, because our ambulance and EMS crews are trained to at least look at the refrigerator to find these forms. If there's no one to talk to. So if you have these, please make them visible. That's why they're bright yellow and bright pink, so they're visible. Perfect. So that's sort of my framing around where we're at as a population for end-of-life care planning and healthcare planning, but also just my perspectives on talking to people about these, how to plan for life stages. My hope is that we have some time now to actually talk about what that means. How much time do we have?
We have about 12 minutes, and I'll pass a mic. If you've got a question or comment, it would be great if you would talk into the mic so it's picked up for people listening at home. Yeah.
Thanks. First of all, I wanted to say this very significant presentation, and I thank you so much for it. I was just going to share a personal story of my wife and my experience with the death of her two parents, who did not have end-of-life plans in place, although had a number of other things in place, and how disruptive that turned out to be for our family and my wife's two younger sisters. We were in Singapore at the time, actually, with Duke. My wife and her sisters decided, because her parents had expressed the desire to die at home, that they would each go to Fort Worth, Texas, from living a long distance away, and spend a month. And the parents had resources for in-home care and a boutique doctor who was absolutely brilliant. But that meant my wife had to go every third month from Singapore, more than 30 hours, to Fort Worth, and it became increasingly straining on us for me to continue there. So it drove actually retirement from Duke so that I could participate and we could be back. Now, what was the most complicated, and I won't go on further, there were a lot of nuances, but that my wife and one of her sisters agreed strongly that all effort should be made to keep her parents alive, who went through vascular dementia and compounding issues of her father and strokes, and it turned out Alzheimer's for her mother. The youngest, the middle sister rather, was staunchly in favor of do nothing. Let them go. So this led to extended discussions between the sisters. We, sons-in-law, wisely stayed out of that, and they came up with a compromise that whoever was there for their month would make the decision. And that worked out reasonably well. This gerontology boutique doctor turned out to be absolutely brilliant, and it took 5 years for both of her parents to die, which was extremely complicated for us and for the whole family. And I think if they'd had their own guidelines in place, it would have saved a lot of family tension, which is fortunately now resolved. So I just can't emphasize the importance of putting down your wishes or sharing them with your kids. And they had no guidelines for their services afterwards. That was less of a controversy, but still led to some controversies. So we have made a point talking with our children. We've even thought about perhaps going and living, if we have some guideline, near one of our children so that these travel disruptions and all, not living with them, but in assisted living care. But I think that the end story here is the importance of planning and how complicated and challenging and increased tensions it creates if you don't do that.
Yeah. Thank you for sharing that. I know that was probably a hard time for the family, and an interesting and unique compromise that I don't think I've encountered that one specifically of the caregiver who's there is helping decide what that looks like. But I think you bring up several good points. One is the idea that when we ask people what they're most concerned about at the end of life, people are concerned about being a burden on their family. And when you poll people about it, and that takes lots of different forms. Sometimes it's the caregiving side of things. Sometimes there's concerns about financial burden. I know these things are often hard to talk about as families, but I think you're exactly right. The idea of laying the groundwork for these conversations is so that when those times come, you can focus on being, family members instead of other things, guides for healthcare or whatever it might be. Like you can focus on your role as the family member. And you're right. The vast majority of people I talk to have not. Many have not laid any sort of conversations about this, and that's challenging. And so a lot of the conversations are around like, well, before so and so got sick, tell me, how did they feel about doctors? Or I see that they were in the hospital 4 times in the last 6 months. What were those experiences like? To try and understand kind of, if this person could speak right now for themselves, what would they say about the medical decisions they're facing, based on prior experiences, based on what's important to them? Because I have so many folks who say, oh, well, the last 3 admissions to the hospital were really, really difficult. Dad with his dementia got really confused and didn't know what was going on, was pulling at all of his IVs and lines. And it was clear that was not helping him in any way. And so then we're able to say, okay, well, based on that experience, let's plan for the next event like this. And that way we can use the prior experiences to help guide. But it's challenging when nothing's been talked about before. Yeah. Oh, sorry.
Quick question prompted by your medical slides, the most
Yeah.
and the DNR forms. An intergenerational question, perhaps for other families and your family in this parish. It occurs to me that seeing those kinds of forms on grandma's fridge or on our fridge would prompt conversations with kids.
Yeah.
And I'd welcome any insights you have about that. When my son was in first grade, I think, and a prodigious reader, he located a binder on my mom's bookshelf that was entitled, "If I Get Hit by a Bus." And he came down to the to the dinner table and said, "Maymay has a notebook called," so
Yeah.
without
That's great.
scaring people or making it a subject of constant conversation, what's your guidance for intergenerational?
Yeah, great. The answer is slightly different for children versus kind of like young adults. For those with children, without going into too much detail about it, we know that children's understanding of like health and also death evolves greatly over their like 18 years of childhood, and so I believe firmly, and I think most I don't do a lot of pediatric work, but those of my colleagues who do pediatric work reinforce that like we don't give children enough credit for being able to understand and kind of be intuitive about what's going on and what things mean. So first of all, I encourage people, like, it's not about hiding things from the children. Like, children will figure it out, right? Like, they know. But we also get to choose, like, what we get to choose is kind of how we talk about it. And so I tell people to be honest. Like, if there's like a loved one in the household who's dying, like, it's okay to be honest about that, but we get to choose the language around what that is. And so when I talk to children and adolescents who maybe their parents are dying or something like that, I'm explaining in simple terms that, like, I'm concerned that, or let's use an example, like, mom's got a most form on the fridge. This is mom's really sick. There's maybe the death conversation is a different one, but let's say we've already had that conversation, and this helps doctors and other people know what mom wants right now. Like, it's simple language, but it's honest. I've seen people bend the truth and not tell the truth about these things. That's just kids know more than we give them credit for. I don't know, does that answer that question? Maybe. Okay.
We have two questions back here,
Yes.
so I'll start.
Sorry, not a question. This is from personal experience. I'm the oldest of 4 kids, and my parents, I believe my mom's, the death of her father, her mother died when she was fairly young, in her 60s. And anyway, when my grandfather died, there was quite a bit of back and forth between my mother and her sister. And I think that impressed on them enough that we're going to do this differently. And for years, as my folks were probably close to my age, and they talked to an estate lawyer, got everything laid out, they got trust set up for the grandkids, and for each Thanksgiving, we would sit down and Artie would have the family talk. And they'd go through item by item of what their wishes were. And it really impressed upon the 4 of us, and we're a pretty tight-knit group where there's not any conflict amongst the siblings. So we're kind of a united group, and so it really was beneficial when my dad went into dementia. My mom's currently 97, and she has dementia, that we knew this is what they want to happen, and it helps us go through the process. So it's very important for us to pay attention to this. Thank you.
Yeah, absolutely. And you kind of touched on, once you've had those conversations, being an advocate for whoever you're the surrogate for is super important, and making sure, like, the role that we talk about kind of sounds fancy. When someone is a surrogate for somebody else for their healthcare decision making, we call it substituted judgment, meaning you're substituting yourself for that person if they can't make decisions. So it's really about making decisions as the patient would, not trying to avoid introducing your own bias as a child or sibling, whatever your personal relationship is, not doing what you would do, but what you would have that person would choose to do. And you're right, laying the groundwork helps you be in that substituted judgment role. Yeah.
Thank you for the presentation. I have 2 questions. The first is on the DNR, the do not resuscitate. Can you clarify? My understanding on a DNR is you're not necessarily terminal. You go into the ER, and I think that's important as opposed to a healthcare POA or living will that you could be in a car accident, but if you have a DNR, nothing will be done to you. So that's number one. And number 2, I want to make sure I heard you correctly. Early on you said that the people, I thought you said, and it seems counterintuitive to me, that people who are spiritual seem to want to prolong their life, which seems, as I say, counterintuitive, that people who are spiritual would kind of be content with their life ending at the right time, as opposed to prolonging it.
Yeah.
Did I hear that right?
You heard that correct, and I'll expound on it a little bit because it's important. But to your first point, yes, lovely. A few, I think, misconceptions happen with things like the DNR form or other documents. So I'll touch on one thing that you didn't mention, but you kind of got close to. So like if someone has like a healthcare power of attorney, like healthcare POA, healthcare power of attorney, or other advanced directive, I just want to be clear that those things only apply when the person cannot speak for themselves. Like I think people get really concerned that like they're going to be like awake and conscious and fully with it, and then someone's going to swoop in and override what they have to say. So long as you are awake, alert, and can make decisions and think about them, your advanced directive and your healthcare power of attorney are like not in the picture yet. The DNR form, there's a huge misconception that if someone has a DNR form, that means like don't do any other medical care for that person, and I think that's what you were getting at. I tell people when I talk to them about what we call their code status, attempts at resuscitation, attempts at being on a breathing machine. And I say attempts because like a do not resuscitate order, those only apply if someone's like heart or breathing stops. Like basically, like they apply when someone is dead. Like if we're speaking bluntly about it, like their heart has stopped. They are dead, and so it's really attempts at resuscitation. It's not like a switch where we like flip people back on. Often those things are not successful, but it's really about, do you want us to attempt those things or not? And so the DNR form, I tell people very clearly when we've decided to not attempt resuscitation or not be on a ventilator, I tell people explicitly, this does not impact any other piece of your health care. Like, I have plenty of patients who are undergoing full cancer treatment, who are undergoing surgeries, and sometimes for surgeries we have to like flip back their code status to be a full code while they're in the surgery, but they know that like even if they're undergoing aggressive medical treatment, like that, but they've set a limit, like if my heart or breathing stops, I want a natural death at that time, and that's how I frame it to people. Yeah.
But people's heart stops, and then it starts up again. So if you have a DNR and my heart stopped, would that be the end? Or would you attempt, even if I had a DNR?
Gotcha. If you have a do not resuscitate order, then that is an order for the medical team to not attempt any resuscitation. So no chest compressions, no medications, no shocks, and so I only want people, doing a DNR or do not intubate order if they are truly looking for a natural death without those attempts. Yeah. Excellent clarification. Perfect.
So that's spiritual and religious.
Oh yes,
thing.
the spiritual and religious.
I've got an idea, but
yeah, it's a fascinating thing, and there's not one answer to why that is, but a lot of it has to do with I'm going to use a Christian lens, but this applies to applies to non-Christians as well in some of these studies. But especially the Christian patients I work with, there's a lot of I'm going to be careful about not putting like spirituality in people's like mouths, but feelings around God will intervene and decide when it's my time to die. And so there is a lot of interest in prolonging life so that God can help make that decision. Some of that is tied up in belief in miracles, that there will still be a healing miracle that will help me. And some of it just has to do with purely that this is not a decision for me or doctors to make, this is a decision for God to make. Yeah.
We are out of time. This has been so amazing. Thank you. If people have questions, can they hang out for a little bit?
Yes, and there are resources up here. Some example most forms, several advanced care planning documents, some things about anticipatory grief, advanced care planning in general, a Spanish language advanced care planning document, if anyone wants a Spanish language one. There's even a form I found in our office about we didn't talk about like death and burial, but like if people are interested in aquamation as an option, we have some information on aquamation, and I'm happy to chat afterwards too.
Thank you so much.